Today, we're diving into a clinical problem that has quietly morphed from a common skin complaint into a really complex global challenge. We're talking about recalcitrant dermatophytosis.
So let's start with the big question. Why are these fungal infections, which used to be so straightforward, suddenly so hard to manage? For decades, dermatophytosis was a simple diagnosis with a simple fix. But a crisis, which really exploded out of the Indian subcontinent, is now forcing us to completely rethink how we diagnose and treat it. All right, so to really get a handle on this, here's how we'll break it down. We'll look at how the threat has evolved, the core reasons for this resistance, the clues for diagnosis, the new rules for management, how to make the cure stick, and finally, the bigger picture of this as a global health challenge. First up, it is absolutely essential to understand the sheer scale of this change. We're not just talking about a tougher infection. We're witnessing a shift from a minor nuisance to a full-blown public health crisis. I mean, the change is just stark. If you look at the time before 2010, cases were sporadic, pretty benign, and easy to handle with a short course of treatment. But after 2010, we're seeing an epidemic of chronic treatment-resistant infections that need long, drawn-out therapy and, critically, are spreading through entire families. Now, while this is a global problem today, we have to recognize that the Indian subcontinent is the epicenter. This is ground zero, where this dramatic shift really took hold and intensified before it started spreading around the world. So what's actually driving this resistance? Well, it's not just one single thing. The crisis is really built on several key factors that all work together. We call them the pillars of recalcitrance. Before we go any further, let's get our definition straight because this is so important for clinical practice. Recalcitrant dermatophytosis is an infection that either fails standard therapy, keeps coming back again and again, or just persists even when you think you're using the right treatment. Understanding this definition is really the first step. So this is a truly multifactorial problem. It's driven by changes in the fungus itself, by treatment factors like misusing medication, by the patient's own immunity, by environment and behavior, and of course, by gaps in public health. Each one of these pillars is propping up the crisis. Okay, so knowing the causes helps us focus on how to actually identify it. Recognizing the key clinical signs and having a solid diagnostic plan is the critical first move towards managing this effectively. Clinically, there are several big red flags you need to watch for. Be suspicious if you see extensive, widespread lesions, especially if they look a bit strange or have fuzzy, indistinct borders. The classic sign, of course, is tinea incognito, where topical steroid use has completely messed up the typical appearance. Also, look for chronic changes from all the itching, really high relapse rates, and clear clusters within families. Your diagnostic approach has to be systematic. You start with a direct KOH mount. That's your first-line test to just confirm you're dealing with a fungus. If the case is recurrent or failing treatment, you absolutely have to move on to fungal culture and molecular testing to figure out the exact species and check for resistance. And finally, you have to do a full evaluation of the host to look for other medical problems or hidden sources of infection. And for anyone focused on exams, this is a high-yield point. Molecular testing specifically targeting the SQLE gene is vital. Why? Because this analysis tells you if there's resistance to terbinafine, one of our go-to antifungals. This isn't just academic, it's absolutely essential for choosing a therapy that will actually work. This leads us right to management. And let me be clear, the old playbook is obsolete. It just doesn't work anymore. We need a whole new set of principles. A new doctrine, really, to guide our strategy against these tough infections. The first principle is the foundation for everything else. Confirm, don't assume. This means you have to get that mycological confirmation before you start a patient on a long, expensive course of antifungals. If something isn't responding, you have to go back and confirm that diagnosis. The second principle is a call to action. We must stop the irrational use of topical steroid creams, especially those over-the-counter combination creams. They make the infection worse, they can fuel resistance, and they're what cause that tinea incognito presentation. Stopping these is often the single most important first step. Now, this one represents a huge shift in mindset. Treat to cure, not to clear. Just because the rash looks better doesn't mean you're done. The goal has to be a complete mycological cure, confirmed by lab tests. Stopping treatment too early is one of the main reasons these infections keep coming back. And finally, we have to zoom out from the individual patient. You have to treat the unit.
This means screening and, if you need to, treating everyone in the household. Family members can be silent carriers, creating a constant cycle of reinfection if you don't manage the whole family.
So, with those principles as our foundation, let's get into the specifics, the strategies and preventive measures you need to not only get a cure, but to make it last. Our treatment strategy really has two arms. Systemic therapy, with drugs like itraconazole, is the mainstay for extensive disease. But with resistance to drugs like terbinafine on the rise, therapy guided by culture results is now key. On the other arm, topical therapy is a crucial support player. It helps the systemic treatment, and remember, it has to be applied 2 centimeters beyond the edge of the lesion.
Preventing recurrence is absolutely paramount. This means regular follow-up appointments every 2 to 4 weeks to check on things. Patient education is also critical, talking about things like laundering clothes in hot water, not sharing towels, and constant reminders to stay away from those over-the-counter steroid creams that got them into this mess in the first place.
Okay, let's zoom out again, because this is so much more than just treating individual patients. Recalcitrant dermatophytosis has truly escalated into a major public health challenge, and it has clear global implications. The critical point here is that this is no longer a localized problem. The exact same terbinafine-resistant strains of Trichophyton indotineae that were first found in India have now popped up in countries all over the world. This confirms it's a true international threat. And this has definitely not gone unnoticed. The World Health Organization has officially recognized how serious this is. They've actually included resistant superficial fungi on their fungal priority pathogens list. That's a major signal that this needs urgent global attention. So all of this leaves us with one final critical question. In this era of rising antifungal resistance, what is our shared responsibility? Because this problem can't be solved by clinicians alone. It's going to demand a collective effort from everyone, from informed patients, from diligent doctors, and from proactive policymakers to get a handle on this growing epidemic.